Hello and welcome to the topic Long QT Syndrome in the Cardiology module. By the end of this session, you should be able to define Long QT Syndrome, describe the causes of Long QT Syndrome, outline clinical features of Long QT Syndrome, interpret ECG of Long QT Syndrome, and discuss the management principles of Long QT Syndrome. Let's get started. So what is Long QT Syndrome? It is a cardiac rhythm disorder characterized by prolonged ventricular repolarization, which is shown by abnormally prolonged QT interval. A QT interval is the total time from ventricular depolarization, which is the QRS complex, to complete repolarization, which is marked by the T wave, measured from the beginning of the QRS to the end of the T wave. It is important to recognize as it may lead to ventricular tachycardia or torsade de pointes and can therefore cause collapse or sudden death. A normal corrected QT interval is less than 430 milliseconds in males and 450 milliseconds in females. The QT interval is corrected in calculation because the length of the interval may vary according to the heart rate of the person. The Bezet's formula is used to calculate the corrected QT interval. Let's look at causes. The inherited causes or congenital causes of long QT syndrome is due to the mutation in genes associated with cardiac, potassium, and sodium channels. This is triggered by exertion, emotional events, stress, postpartum events, and noise. There are more than 13 types of identified assorted with mutation in genes encoding myocytes ion channels. The most common variants of long QT syndrome are caused by defects in the alpha subunit of the slow delayed rectifier potassium channel. The two distinct long QT phenotypes due to mutant alleles in the same locus are the Romano-Ward syndrome, which is an autosomal dominant condition without hearing loss, and Jervell and Lange-Nielsen syndrome, which is an autosomal recessive syndrome with congenital sensory neural hearing loss. As for the acquired causes, usually it's caused by certain drugs or medications, and the common mechanisms involve blockage of rapidly activating potassium channels encoded by KCNH2 gene. Examples of these drugs are amiodarone, sotalol, Class 1A antiarrhythmic drugs, tricyclic antidepressants, and SSRIs, methadone, chloroquine, terfenadine, erythromycin or macrolides, haloperidol, and ondansetron. To make things easier, alternatively, you may use a mnemonic to remember the drugs that cause prolonged QT interval, and the mnemonic is called TO for SATs, T for thiazide diuretics, O for olanzapine, opioids, quinolones and quinidine, S for SSRIs and sotalol, A for antihistamines and antipsychotics, D for antidepressants, and E for erythromycin or macrolide antibiotics. Well, there are other causes of acquired prolonged QT syndrome, which include electrolyte imbalances such as hypocalcemia, hypokalemia, and hypomagnesemia. We have acute myocardial infarction, subarachnoid hemorrhage, hypothermia, and also myocarditis. This is the diagnostic criteria for congenital long QT syndrome. The domains which are looked at are the ECG findings, clinical history, and family history. This condition can be incidentally picked up on routine ECG or following family screening. Long QT1 usually is associated with exertional syncope, often while swimming. Long QT2 is often associated with syncope occurring following emotional stress, exercise, or auditory stimuli. And long QT3 usually follows events occurring at night or at rest. And finally, we have the sudden cardiac death, which is another feature of prolonged QT syndrome. This ECG shows the evidently increased QT intervals on almost all the leads. The heart rate on this ECG is about 80 beats per minute. The corrected QTC interval for the rhythm on this ECG using the Bazet's formula is 490 milliseconds, which is significantly prolonged. When it comes to management, it can be largely grouped into two for congenital and acquired causes. Beta blockers can be used to blunt the adrenergic response in congenital long QT syndrome. Take note that STOR may exacerbate long QT syndrome as well. For acquired long QT syndrome, importantly, avoid drugs which prolong the QT interval and other precipitants if appropriate. A non-sedating antihistamine and taken together with P450 enzyme inhibitor is a classic case of acquired long QT syndrome. For example, patient with a cold takes terfenadine and erythromycin at the same time. Also not forgetting, treat any abnormalities in electrolytes identified. Magnesium sulfate is used as treatment and prevention of recurrence of long QT syndrome related ectopic ventricular beats. Lidocaine and sometimes phenytoin can shorten the duration at the action potential as well. Pacemaker can be placed if bradycardia triggers arrhythmias, and implantable cardioverter defibrillators in high-risk cases. Let's take a look at the indications for an implantable cardiac defibrillator. So of course, we're thinking of long QT syndrome. Other indications may include hypertrophic obstructive cardiomyopathy, previous cardiac arrest due to VT or VF, previous myocardial infarction with non-sustained VT on 24-hour monitoring, and Brugada syndrome. So in summary, long QT syndrome can be life-threatening if not treated and managed early. Its most feared complication is sudden cardiac death. Long QT syndrome can be diagnosed using the Bazet's formula, and causes can be classified into congenital and acquired causes. Firstly, identify the risk of one developing prolonged QT, mitigate the risk and avoid administering drugs that can precipitate prolonged QT interval in someone who has a risk to develop one. Beta blockers can be used to manage the condition if the condition is deemed high risk or if it is congenital in nature, and implantable cardioverter defibrillator implantation would be warranted. So we have come to the end of this topic. Thank you.